thank you, and thank you for inviting me to speak today. And these are my disclosures, none of them affecting my presentation today. So we will briefly review the structure and HMO levels and variation. I think this is not a new topic for most of you. And then again, I will summarize where we are in terms of findings from randomized placebo-controlled clinical interventions. And I would, though, refer you to this wonderful booklet that's been pulled together that's outside, because there are some studies that I'm not going to be presenting that are in that, as well as just a really nice review of the functions. And then I want to compare with some of the observational evidence, because we have kind of two bodies of evidence. We have the very well-controlled, randomized controlled trials of supplementation infant formula, but then we have observational data where the normal variation in human milk allows for looking at associations with outcomes. And then finish kind of briefly with some proposed mechanisms and a study where I think that we can actually revisit existing data and apply techniques like machine learning to understand mechanistic work in human studies. So I want to take a step back, because today we're really focusing on HMOs and LC-PUFAs, but I think as Juan mentioned, you know, the evolving concept is really that human milk is a biological system, and that this is a nice figure, but I have to tell you, HMOs is not on here, so that's a little bit of an issue. But this concept that we can't just look at one of these, and it really works together in a complex matrix. And that also that human milk is a system within a system, so we have a very complex interactions. You've heard about milk fat globule membranes and lactoferrin and osteopontin and all of these individual components, but they're all working together. And that because of the uniqueness of the mom's ability to react to the environment, as well as the genetics that Bert just mentioned, which I will talk about genetics with HMOs as well. But we have that there's what we now call the triad, which is basically the lactating parent, human milk, infant triad, so that milk can adapt. So for example, with COVID, the production of COVID antibodies. But we do know from both direct clinical trials and epidemiological data that human milk does enhance child systems development and health. And I think that was what Jose was also referring to in his introduction. So focusing on HMOs, and this is probably a common graph that you've seen, you know, the unique aspect here is that human milk contains a large quantity. It's the third most predominant solid component, but it's much lower in bovine milk. So traditionally, cow milk-based infant formulas have been pretty much devoid of HMOs, and to fill that gap, we were using different prebiotics. And now there's more of a push as HMOs become available in sufficient supplies that we can begin to supplement them. So you can see the differences of a range of 3 to 16 grams per liter in human milk versus about 0.05. But the structures are similar. We see different, also human milk is unique in the numbers of structures that are there, and particularly the degree of fucosylation, which is different than any other species, including great apes, that we would think would be most closely related to. But if you have 6SL in bovine milk, it's structurally identical to the 6SL in human milk. So even though we call them human milk oligosaccharides or bovine milk oligosaccharides, they're structurally the same. So again, you may have seen this, but basically we start with 5 core monosaccharides shown here, and we also start with a core structure of lactose. And basically these can be elongated, fucosylated, and sialylated, and this is where we get up to the 200 different structures. And so we oftentimes categorize them as neutral fucosylated, neutral core. These are sometimes now referred to as acetylated, and the acidic sialylated. And this is a recent review, which basically shows human milk mean from 14 to 90 days of lactation. And so you can see that in what we'll refer to as secretor mothers, the 2FL or 2-fucosyl lactose is the predominant HMO, and then also some of the elongation products of 2-fucosyl lactose. And this just to show you, this is data from the child cohort in Canada. So these would be the milk of non-secretors. And typically, so this is about a third of the mothers in the cohort. And this is 2FL. So what we typically see, the absence of 2FL, is that the milk of non-secretors has quantitatively less HMO available. And this is just as a percent of total. This is another nice figure that, as we see in the non-secretor mothers, there's other HMOs that are in some ways almost compensating for that. We see more LNT, more 3FL, and others. So, while we talk about human milk oligosaccharides, I'll mention that we do need to think, just like Bert was talking about genetics, that there are genetic differences, and so infants are not receiving all the same human milk. And so this is, again, a recent review that I will refer you to, but basically a review of the literature. And so you can see that, in general, there's a slight decline in HMOs over the course of lactation. But if you look at individual HMOs, they do follow different patterns. So this is what I was referring to in what we call secretor status. So a woman's genetic having the 2-fucosyl lactose, 2-fucosyl transferase, that adds the fucose not only to HMOs but also onto cell membranes. And so, for example, in a lot of European countries, you see that it's 22 to 23% of the moms, but just like Bert mentioned with the LC PUFAs, there's a lot of variation. So in South American countries, you can see in Bolivia, Peru, and Brazil and Argentina that most of the women are secretors, and so their milk is very predominant in 2FL, whereas mothers in Africa, on average, had the lowest percentage of secretor status. So currently, we're adding 2FLs to all infant formulas, but not all babies are getting human milk with 2FL. So why do we care? Basically, you've probably heard a lot about this, that HMOs are multifunctional for the human infant, and we're really, I think, just scraping the surface in terms of our understanding, and particularly at the mechanistic level. But, they affect numerous glycan-mediated processes, a lot of them within the gut, microbial colonization, specific strains of bifidobacteria, B. infantis, as well as Bacteroides, can utilize these HMOs. There's also in vitro evidence predominantly that HMOs can affect barrier function and gut development. And probably some of the strongest evidence is that many pathogens have evolved to bind to fucoses and sialic acids on cell membranes. So the presence of these fucosylated and sialylated HMOs basically can act as decoys and either bind up the HMOs within the lumen and pull them out. So we can see examples of the rotavirus or norovirus actually being shed into the stool of an infant or an adult, but it doesn't have an opportunity to bind to the cell membranes. We also see that some HMOs, a very small percentage, can enter the circulation and may have systemic effects as well. And one large area of interest recently is the gut-brain axis, where these changes in HMO and the metabolites can be impacting the brain and also directly potentially providing sialic acid for the brain. So because of this broad range of positive outcomes, there's been a big interest in the potential to start to add these to infant formulas to help to narrow that gap. And so currently, there's 7 synthetic HMOs, predominantly from fermentation, but also produced in other ways. And so these are the 7 up here. I had to add DFLNT to this one. But you can see there's some of the simpler structures, but we have sialylated, fucosylated, and some of the acetylated or neutrals. And again, I'm going to focus primarily on the studies where these have been added to term infant formulas without the presence of other probiotics or some of the hydrolyzed formulas. So the 2 first studies added either a single or 2 HMOs because that was what was available. But as you can see from the out in the booth, that there are some that are now adding more. So just to I really want to give you an overview because some of these are a little bit older studies, but some of the early ones with Marriage and Gehring, where they had a breastfed reference. This study actually, they included galacto-oligosaccharides, so they were going for a total 2.4 grams per liter of combination prebiotic and HMO. The doses that they looked at were 0.2 or 1 gram per liter, which is quite a bit lower than a typical secretor mom. And they only added one. The Puccio study, a little bit higher concentration, 0.5 gram of 2FL and 1 gram of LNNT. Just to refer, so these are from the recent paper, so you can see where these are sitting in terms of the typical concentrations and ranges in human milk. So these are some newer studies. Parshat came out just in 2021. Again, a much higher total HMO concentration, and some of these you can see are getting close to the range in human milk. There's also, and I saw part of a presentation this morning that included this. I've only seen this in abstract form as well as in clinicaltrials.gov, but this is actually formulas that are including 5 HMOs. And so, we're definitely starting to narrow that gap a bit more. And just to summarize the overall results, and here I'm comparing to the formula-fed control. And what I would say just overall, that the weight, length, head circumference, so the overall growth, there were no significant differences. In most cases, the GI tolerance, stool consistency, stools per day were similar, except in this study, again, possibly because they were more at a 5.7 gram per liter. These were some of the Gehring study actually looked at some cytokines and were able to show, I think, more of a functional outcome, where they found a 29 to 83% reduction in serum pro-inflammatory cytokines, and the levels were actually similar to human milk. And in the Puccio study, they also looked at maternal or parent-reported comorbidities, and they found lower bronchitis and lower use of antipyretics and antibiotics. So definitely, they've been showing safety, and there's some indication of efficacy. So now stepping back, so this is what we see when we add the HMOs to an infant formula, and then this is from a recent very nice review by Norbert Sprenger, where we were looking at, these are the types of studies, so these RCTs I just mentioned, as well as observational studies. So these are associations between HMOs, and in some cases it's diversity, some cases it's specific HMOs, and the reduced risk of health-related outcomes. So I think that this is some of the strongest evidence, particularly for some of these infectious diseases, that the presence of HMOs in milk, as well as in the RCTs, was reducing the risk of some of these health-related outcomes. The other topic that we hear a lot about is growth. And there's been a number of studies, so here predominantly observational studies, that are suggesting that there's some association between either the HMO abundance or specific HMOs and various growth outcomes. But basically what you're seeing is this is positive, this is negative, so there's inconsistent and oftentimes contradictory associations. The effect sizes are modest, and they're all within the range of normal growth trajectories. And importantly, on that slide I showed you, in all of the RCDs, there's never been any reported differences in growth of those infants when you add the HMOs to the infant formula. So at this point, whether HMOs can improve growth in term healthy infants doesn't seem to be well supported. There is a suggestion, though, that HMOs could potentially improve growth in malnourished or preterm infants. This is unknown and should be studied. So I want to talk about another recent study that was just published, where the authors went back to the Puccio study. So this was the study where they either added half a gram of 2FL and 1 gram per liter of LNNT. So to remind you, the clinical observations were that there was reduced parent-reported bronchitis and lower respiratory tract illnesses. They also, in another paper, showed there was modified fecal microbiome and metabolites. So in the group getting this combination of 2FL and LN and T, they found differences. They found higher bifidobacteria and higher acetate. And so they went and basically used a sparse partial least squares discriminant analysis and machine learning to go back to see were there any associations or relationships between these clinical outcomes and the biological measures. So basically this is the PLSDA. So this is the variance explained both for the metabolite as well as the cases and controls. And in this case, I'm just going to focus on the lower respiratory tract infections. So you can see that they were able to pull apart the cases and the controls, and they had about a 2-to-1 ratio. So then when they started looking at what were the components, what were the factors that were loading into pulling these two groups apart, they found some positive and some negative factors. So here they were finding that bifidobacterium abundance, the presence of fucosyl glycans, so basically the 2FL, the product, which would be the test formula, and the percent acetate in the stool were all basically positive. So it was a loading weight, but the directionality was responsible for pulling them apart. So then they went on to further look at, so this is some of the actual data where they looked at cases and controls, and these are the different metabolites, the volatile fatty acids. And what they found is that in the cases, there was a difference. There was lower acetate statistically. And also in the cases, they saw a reduction in the B. longum subspecies infantis. And that's one of the B. longum that has the HMO cassette that allows it to metabolize. So then they looked at the relationship between the abundance of B. infantis and acetate and found a nice linear relationship. And then when they looked at different species, again, the strongest, they saw positive correlations with the sum of bifidobacteria, longum, subspecies longum, and subspecies infantis, but not with other species of bifidobacteria. So again, this was a nice example of where we can go back to existing data sets and apply some of the newer techniques. So I just want to kind of end with what I think are some of the future opportunities. And again, many of you may be familiar with this, I would say a really nice series of studies over the last decade by Lars Boda's group. And so Lars is at UC San Diego, and he started in a rat model of neck and very elegantly showed that a specific HMO, DSLNT, was improving survival and pathology scores in this animal model. And he cleaved off like one sialic acid, so he showed you needed both sialic acids, you needed the full structure. He then went on to collaborate with a group of neonatologists to basically look at, was there a relationship between DSLNT and in mother's milk and preterm infants with babies who developed neck. And they did find that DSLNT was lower in the milk of mothers of preterm infants who developed neck. And then more recently, in a study that I think got a lot of press, it was with Christopher Stewart and Nicholas Embleton. So they basically applied methods where they could look at the correlations, and they also found some microbial factors, but what they were able to show is there was actually a threshold cutoff which was able to have a sensitivity and a specificity of 0.9. So by measuring the level of DSLNT in milk, they were able to have a very high specificity for an infant who would be at risk of developing neck. So it's really that biomarker that we're looking for. And he's recently published a paper where we can maybe get to a bedside device where you could actually measure these and do point of care at the bedside. Right now, producing DSLNT is challenging, but technology will be able to solve that problem. Currently, preterm infants don't contain any HMOs, which I think is a huge gap. So to summarize, HMOs are multifunctional components, and again, if you look at the brochure that was developed, you'll see lots of different functions in the studies that support those. They really are I think going back to the beginning, I mean, this is, the question we always have is, why is there so much in human milk? Why do we have this variability? And, this is a component that mothers spend a lot of energy producing that doesn't nourish her infant, but it's definitely providing other benefits. Most the studies have all shown that the levels and the combinations that have been supplemented are safe and achievable. And again, I think some of our future directions would be additional mechanistic research. There's lots of preclinical, but can we also apply newer statistical and analytical machine learning AI approaches to existing data sets? The area of HMO and neurocognitive outcomes I didn't talk about, but there's a lot of preclinical animal work in rodents as well as in our piglet models that we use, and also some associations, but we need to be doing more interventions, RCTs, with our cognitive outcome as a measure. I think supplementation to preterm infant formulas as well as other specialized formulas. And another area that's really emerging is applications beyond infancy. So you're seeing a lot of papers coming out in adults with irritable bowel, but also even in the elderly as a way to enhance immune function.